Yes, sir. So you are live now. You can start with the session.
Hello, everyone. This is the Facebook Live interaction, and I'm Dr. Bharat Bhosale. I'm a medical oncologist, consultant at Bombay Hospital. I'm the director of Sunrise Oncology Daycare Centers, where we provide daycare facility for chemotherapy administration. And the subject for today's discussion is prostate cancer. So, if there are no members join for the discussion, you can put up your questions in the chat box. I would be glad to answer all those questions based of my knowledge and experience. So, so first thing is how common is the prostate cancer and in what age group the prostate cancer is really important. Where which subset of patients, what age group should look for the signs of this kind of symptom signs of this particular cancer. So prostate is an organ which is a important part of the genital system. Other organs like kidneys, bladder, and this is an important cancer for males beyond the age of 50, 60. Usually, what happens after as the aging starts, the prostate grows in size, and all the males after the age of 60 they start developing symptoms related to the prostate, which is called as a normal condition called as a benign enlargement of prostate, which happens as a natural process. The number of prostate cells increases in size, and there is an obstruction to the urinary tract flow downstream, and the symptoms like increased frequency of micturations, night time, the patient or the person has to go to the urination more frequently. These are normal symptoms which can be treated by urologist uh, with the tablets and in certain cases surgeries, but these are non-cancerous things. Though the size of the prostate increases, these are non-cancerous things. And prostate cancer also happens in the same age group, and the symptoms are more or less are same. So if somebody is facing these symptoms, it is best to see a urologist, a neurosurgeon, have particular examination. It's a clinical examination called as the digital rectal examination. And if that is the cornerstone, that clinical examination is the most important thing where urologist can identify if there are cancerous changes. As I mentioned, normal enlargement happens in all males after 50, 60. As their age increases, as you grow older, the prostate naturally becomes large, but there has to be a screening. So what happens in western countries, there are screening protocols in place. In developing countries like ours, the problem is that we don't have set protocols for the prostate screening. The main problem is the infrastructure, health infrastructure. We already face so many other more important health problems. So there is no screening at the public level. But yes, digital rectal examination and PSA examinations. PSA is a blood test wherein you just draw a blood test and do the PSA levels. And if it is elevated and the urologist say there are some changes which kind of no cancer, then the next step is to confirm whether it's a cancer or not cancer. So at this particular age group, if somebody is facing symptoms such as frequency of picturation, frequently in the night you have to get up and go to the washroom. So these are the symptoms usually of benign enlargement of prostate, that is called as BEP, which is non-cancerous condition. But somebody having a family history of cancer, they have to take extra precautions. Family in the sense, majority of the prostate cancers are age related. As you grow, your risk of elder, your risk of any cancer, particularly prostate cancer, increases. So age is an important risk factor. Then particular races like African Americans have a higher tendency of prostate cancer. That does not mean Indians are protected. Yes, Indians also do develop prostate cancer. So age, race. Apart from that, no, we don't go for testosterone replacement or testosterone therapies. So there are hormones called as testosterone, which also stimulate these cancer cells. So those are also one of the risk factors. Then unfit body means if somebody is obese, not having healthy diet, no exercise, that also indirectly increases risk of any cancer, including the prostate cancer. So these are kind of risk factors. Apart from this, up to 10 to 11% of the cases may have some family history. So some member in the family have breast cancer or endometrial cancer or some other cancer. So those 10% of the cases, the cancer, prostate cancer can also be due to the genetic mutations which are inherited from one generation to the other generation. So while once a patient is diagnosed with prostate cancer, we go and take a detailed history about the family background, because nowadays there are genetic mutations testing available, which if the patient is positive for that particular mutation, especially we call it the BRCA2 in prostate cancer, largely BRCA2 is the most common mutation, which, and apart from that there are 2 3 other mutations. So in a family, if there is a history of prostate cancer, male breast cancer, female breast cancer, so those patients are likely to have some germline mutations, and nowadays there are treatment options available to target these kind of mutations. In prostate cancer, once we are exhausted with the kind of treatment, which is hormonal treatment and chemotherapy and targeted therapy, the last resort we can use these treatments targeting these particular mutations. So this is about the reasons why the prostate cancer happens. It is because uncontrolled proliferation of the prostate cells, which also happens naturally, as I mentioned. But if it is beyond that, it is uncontrollable. It goes beyond prostate and goes beyond prostate into bones and lungs and all other organs. Then it goes into the metastatic stage. So whenever a tumor starts at this age, it is very important to visit your urologist. Make sure that it is a natural growth of the prostate, not the cancerous growth. If the urologist suspects it's a prostate cancer, the best way is to do a set protocol USG guided biopsy, which is called as trust guided biopsy. They take multiple cores from the prostate and a proper histological examination is done. If it is a cancer, the next step is to stage it. They do local MRI, and if the PSA is a tumor marker secreted by the prostate cancer cells. So based on the histopathological report, what grade the tumor is, what is the PSA level, and then the urologist with a team of oncologists decides what imaging is required to stage the disease. Sometimes if the tumor is low grade, limited clinically, we feel that PSA is also low. If it is low grade, only local pelvic MRI can be done. If the tumor is localized to the prostate, based on the patient's age, how fit is the patient? Because on one hand you can have a 50-year-old young fit patients, and on the other hand you can have a 90-year-old a patient who is diabetic, hypertensive, whose heart is not functioning, 10-20% of ejection fraction, who is not fit for any kind of treatment. Then based on the fitness of patient also we decide the treatment. Sometimes a patient is very fit but cancer is in stage 4. Sometimes the patient has stage 1 cancer but patient is not fit for any treatment. That also decides how aggressive our treatment is going to be. So based on your evaluation, sometimes we add PSMA PET scans. These are newer modalities of our PET scans, PSMA PET scans, and we stage them, whether they are localized, whether they are locally advanced, or they are metastatic. And if it is localized, there are different modality of treatment. Sometimes our surgeon colleagues tell us to do systemic therapy, which is a neoadjuvant androgen deprivation therapy, which is a kind of hormonal injections given at an interval of monthly or 3 monthly, reduce the size of the prostate and do the surgery. Most of these patients go for radiation if the surgical margins are positive or the nodes are positive. So evaluation for the staging and whether the patient is fit for surgery, and if the patient is fit for surgery, how to do the surgery, whether to do surgery first and hormone treatment afterwards, or hormone treatment first or surgery afterwards. This is all decided in a tumor board where a radiation oncologist, a chemotherapy person, or a medical oncologist like me, or surgical oncologist sit together. There are different modalities of surgeries. There is something called as a robotic surgery. There is something called as a laparoscopic surgery. There is something called as open surgery. There is no difference in terms of survival if you go for any of these modality. Only thing the hospital stay reduces, and with the robotic surgeries, and the pain is less. But in terms of survival, there is absolutely no difference. These hormonal therapies are discussed again after the surgery based on what tumor comes on the final tumor specimen. And then we give 2 to 3 years of hormonal treatments and keep following the PSA. If the tumor has gone beyond the prostate into different organs, then it is a metastatic disease. In metastatic disease, we do not usually discuss about radical prostatectomy, that removal of the prostate. But then the backbone of the treatment for metastatic prostate cancer has been hormonal treatment. We call it a hormonal manipulation. It is called as androgen deprivation therapy. Since ages that has been tried because it's the simplest treatment. just taking out the source of testosterone or suppressing the testosterone source is the treatment for prostatic cancer, because these prostate cancer cells are stimulated by the testosterone, as I mentioned, and the testosterone comes from the testicles. So there are two different ways of targeting this source of testosterone. One is give those injections which suppresses the testosterone production. These injections are called as a GnRH agonist and antagonist. Based on the comfortability of your urologist and medical oncologist, these are monthly, 3 monthly, 6 monthly injections are available, can be given on outpatient basis. That causes suppression of the testosterone. If a person doesn't want to take a repeated injections, one time surgery is available, taking out both the testicles, but some of the patients are not comfortable with the testicular removal. So if you ask me whether there is a difference in terms of the effectiveness, absolutely both the treatments, one is medical, one is surgical, are equally good. Only problem is in injection, you have to take a repeated injection. Surgery is one time go, but these testes cannot be put back into the place. Now, with this majority of these patients, the PSA which is elevated goes back to normal. The tumors which are spread into the lungs and liver and bone, whatever, bone is the most common site and nodes are the other common sites. They regresses, majority of the patients. But what happens based on what grade the tumor is, how aggressive is the tumor? Sometimes with the androgen deprivation or hormonal manipulation, we have seen patients in stage 4 prostate cancer are doing good for years, including 10 years. And there are, on the other hand, there are patients who fail within 5-6 months. So this stage where you have just done the hormonal manipulation is called as a hormone sensitive prostate cancer. Once a patient stops responding to hormonal manipulations, their PSA starts rising. That stage is called as a hormone refractory prostate cancer. We also call it as a castrate refractory. Castrate resistant prostate cancer means you have manipulated the testosterone, you have suppressed the testosterone, still the tumors are growing, the PSA is rising. In that case, now comes the role of neuroandrogen therapies, targeted therapies. So initially, we used to try only chemotherapies. 10 years back, there are hardly any chemotherapy agents available for treating metastatic prostate cancer. So once the patient becomes hormone refractory, you have option of choosing oral targeted therapies such as abiraterone, enzalutamide, or chemotherapy drugs like docetaxel and cabazitaxel. Now these same drugs, which I am talking, that you first do hormonal manipulation, let the prostate cancer cells grow, let the hormone treatment fail, and then use all these modality. Now, recently there have been trials where they tried all these modalities like abiraterone, enzalutamide, and docetaxel in hormone-sensitive patient. Let the newly diagnosed patient get either testicular removal or the medical management of giving 3 monthly or monthly injections. Along with that, either start with chemotherapy or these oral agents, and that has shown that the failure of PSA or the stage of castrate-resistant prostate cancer can be delayed by using all these modalities. Now, recently there is a paper from a very good prostate cancer institute in Paris, Farah Kazi, Karim Fazazi, and he has shown that you can actually use chemotherapy, abiraterone, along with the hormonal manipulation, all these modalities together, and that has actually delayed the stage of castrate-resistant prostate cancer. So, newly diagnosed patient, if they are fit, you can use all these modalities together and achieve the maximum response to the all the modalities and actually delay those stages of castrate-resistant prostate cancer. So by doing all these manipulations, what we try to achieve, that patient lives longer with a good quality of life. But what is important in prostate cancer, sometimes there are patients who actually have very low PSA, very low grades of prostate cancer, and they do very well without any treatment, just hormonal manipulation. But we don't have a marker which can identify which prostate cancer patient is going to have aggressive behavior and which patient is going to have a very dormant behavior or which is slow growing. There are conventional factors like grades of the tumor, PSA, the speed at which PSA rises. But again, these are conventional factors which are not highly specific to classify this patient. So that in other cancers now we have one tumor is not treated in different way. Like in prostate cancer in the future, if we have a genomic signature, there are some genomic signatures, so they are not practiced very because one is the thing is cost. Like in early stage prostate cancer, if the patient is very old, as I mentioned, somebody who is 90-year-old, who has very low grade prostate cancer, and and imagine treating them with a very toxic chemotherapies, it itself will cause no damage to the patient's body. So those patients, even without doing anything, they do well because their tumor is growing at a very slow rate. So the grade of the prostate cancer is important. The speed with which the PSA increases is also important. Now, apart from this, in some cases, the tumor has spread beyond prostate and it is spread to a limited part. And if you have done the hormonal manipulations and that metastatic side, beyond prostate, if the organ is involved, one or two sides of prostate cancer site at bones. And with the hormonal manipulations, if everything becomes normal, responds well, and patient stays with a good PSA control for good interval of time, then nowadays local therapies in terms of whether doing local surgeries or radiation are also to be discussed with the patient because that adds again years of survival to the patients. So this is only possible when a patient is managed by a group of doctors who can contribute their opinion to a teamwork called as a tumor board or multidisciplinary tumor decisions, in which all the specialty of doctors sit together, look at the scans, look at the profile of the patient, look at the fitness of the patients, what is the grade of the tumor, what are the PSAs, at what speed the PSA is growing, what are the subsequent scans, and then these decisions are delivered to the patient, which is called as a best management for any cancer patients, multidisciplinary decisions for the cancer patients. So prostate cancer treatment actually has evolved a lot. There are a lot many things have come up. As I mentioned, some of the prostate cancers are genetically related, and there are mutations called as a BRCA. If those are positive, and the patient has already exhausted with multiple lines of treatment, then there are drugs called as a PARP inhibitor which can be applied or used for those subset of patients. And again, these patients get the survival advantage. Apart from this, there are PSMA therapies. As I mentioned, if the PSMA uptake is there on the bone scan, there are certain scans called the nuclear scans. So there is PSMA therapies also can be utilized to control the prostatic cancer, and these patients get survival benefit. So there are not one therapy; there are multiple therapies. But then how to put them one after the other is very very important. By using this treatment one after the other, there is the possibility that no patient survives longer beyond 10 years or 15 years. This is what no prostate cancer has seen in the last 10 years. As I mentioned, now once the patient is newly diagnosed, people are trying to use all the modalities together. The patient has to be fit for that. In chemotherapy also there are many chemotherapy drugs previously, like but now the main drug is docetaxel, and there is one more drug called as a cabazitaxel. These are chemotherapy drugs. In hormones also there are newer tablets coming up beyond abiraterone and enzalutamide. So the field of prostate cancer is evolving. There is something called as a immunotherapy, which has come up in a big way in melanoma and lung cancer. In prostate cancer also, there is I must say that it's not widely applied in prostate cancer. But if somebody is affording and there is some biomarker which says that no, this patient may get benefit from the immunotherapy, something biomarker called as MSI or PDL1, after exhaustion of all these treatment options, if the patient is still fit, and these are the situations where no patient actually takes all the treatment modalities and still the tumor progresses and the patient is still fit. And in such subset of patients, if you want to treat them, then immunotherapy is also one of the treatment options. But again, then you have to uh, explain the patient these are the treatment modalities available for you, uh, and this needs to be explored. It's working. So we have some chat box here. So I have meant no, I have actually answered about so if you see in India, as I mentioned, our main problem is not prostate cancer. We did, our main problem in the metro is breast cancer. If you go towards villages, it's a cervical cancer. Prostate cancer is not the cancer of uh, all age groups. It's limited to the elderly population and strictly males. So, as compared to the other cancer, it is not very common. So, most common lung cancer, oral cancer, cervical cancer, prostate cancer, breast cancer, then GI cancers. So prostate cancer comes down in the line. But yes, the most important thing in India, what is happening with the advances, aging, the aging population in India is increasing. Our baseline population of India is actually very huge numbers. So if once your aging population increases, the number of prostate cancer patients are going to be higher. Once we apply screening, we are going to detect more and more prostate cancer patients in earlier stages. And then comes the question whether no which patient should go for aggressive treatment, patient should not go for aggressive treatment. That is why I was talking about the biomarkers. We should have a such marker which can identify this patient needs treatment, this patient needs aggressive treatment, and this patient may need no only local treatment, like that way, and just observation. So that might be possible in coming years because a lot of research is going on. Then risk factor I have mentioned in brief. As no, these are cancers are more common in Western countries like African and American continent. Yes, Indians are at lesser risk, but yes, it happens in a developing country. Caucasians are at lesser risk. Do males develop prostate cancer? Young males. So I must answer that it is very rare, but I have seen very early age. The earliest age at which prostate cancer I have seen is 40, 30 at 40. That is very surprising. One of no known to person who is around 40 to 45 develop prostate cancer, but it's very rare. Usually, it's a cancer of 99%. It is a cancer of elderly population. Benign hyperplasia. As I mentioned, benign prostatic hyperplasia is a natural process which happens in the prostate cancer. It happens, mostly all the males. So not necessarily every BPH progresses to prostate cancer, but the symptoms are more or less same. Then that's why in Western countries people go for regular screening and PSA testing. But again, high PSA is not necessarily always it's a prostate cancer. The digital rectal examination, which identifies which is BPH and which is not BPH and it's prostate cancer. So that clinical examination is very, very important. Sometimes some infections of the prostate also causes high PSA. What are the chances of survival at different stages of prostate cancers? So I will not quote you now this, but as I told you, in stage one, if you apply surgery, your intention of treatment is cure. In stage 2 and stage 3, sometimes our radiation or surgical colleagues ask us to give neoadjuvant hormonal therapy, bring down the size of the prostate, and they operate or either give radiation. In stage 4, we don't talk about cure, but there are instances that stage 4 cancer patient may survive longer because the biology of the disease is not very aggressive. We have patients who actually had prostate cancer in stage 4 where the bone, and you have just done hormonal manipulations, and for years they have controlled PSA. So it all depends upon the genomic of the tumor, the biological behavior of the tumor. As I said, if the grade is very low, if the tumor is not very aggressive, they remain indolent, even in metastatic stage. On the contrary, you have stage 3 prostate cancer, you have treated, but they fail immediately within 6 months and develop metastasis, and they progress very fast and they don't have a life beyond few years. So this is the stage does not always decide the survival. Yes, but the intention of treatment, whether you are treating with a curative intent or palliative intent, the palliation might go for years, or sometimes the curative patient may fail and become metastatic very fast. If they have a very high PSA to begin with, very high grade of the tumor, we divided these into class 1, 2, 3, 4, 5. Does prostate cancer affects the quality of life? Very, very important question, because the treatment for metastatic prostate cancer is hormone manipulation. Even in stage 2, 3, if the neoadjuvant hormonal therapy is given, we actually do androgen deprivation therapy. Androgen deprivation means you have to deprive the body of androgen. What is androgen? It's a testosterone. It is required for the masculinity in male, the bone structure. If you are taking away the androgen, the testosterone, the body is going to become weak, the muscles are going to be fatigued. There are mental changes which happens, like what no menopause in the females at the age of 50. They, because of the estrogen lag, the females develop menopause. Likewise, the deficiency of androgen is called as an andropause. Then there is a possibility of mood changes, the muscles become weak. So, these symptoms, usually these patients develop tolerance to these symptoms. But yes, no, to deal with this, no, regular exercise is important, counseling of the patient is important. So to extent quality of life is affected. There are trials where no, by not removing the testes in metastatic stages, the injections are being given and the PSA is controlled. If the PSA is controlled for longer duration, they try to take away the injections, but then person has to be very categorical in terms of monitoring the PSA. If the PSA starts rising, you have to reintroduce these injection to suppress the testosterone. But no, this needs very careful monitoring, and hardly we follow. Once we start the hormonal manipulations or androgen deprivation, we continue with. Most of these patients prefer surgery and they undergo bilateral orchidectomy, that is testicular removal, which is like irreversible surgery. You can't place back the testis back to the patient's scrotum. Does prostate cancer relapse? So yes, as I mentioned, no, based on the biology of the disease, some patients relapse after or progress after years or 10 years, and some patients do not respond. And in between, there are patients who respond for 2 years, 3 years, 4 years, 5 years, and then they progress. But yes, there are different treatments available which can again put the disease into remission. Any precautions that can be taken to prevent prostate cancer? So good. So any cancer, not only prostate cancer, a good healthy lifestyle, regular exercise, eat on time, maintain proper weight, avoid sedentary lifestyle, good healthy food, avoid fatty diet, no, have a balanced diet. This definitely helps. If you have a family history, do regular screening to detect those no cancers at earlier stages. This applies to all the cancers. If somebody is eating tobacco, no, they have to do regular screening. Or first thing is to stay away from such addictions. Avoid alcohol or avoid smoking, because every cancer no is related. Almost every cancer is related. There are, it's basically cancer is a multifactorial disease. So these are important things one can keep themselves healthy and stay away from the prostate cancer. I think we have answered all 8 questions. Prostate cancer is one cancer where no it gives time to decide the treatment, and with the treatment, if patient respond, most of these patients do very well. Done. So if there are no more questions, thank you for giving this opportunity to speak on prostate cancers. If there are audience who go through this video in the future, please send your questions. I'm more than happy to address all the queries which are related to prostate cancer, especially, and for any other cancer, any other cancer related query. I'm very happy to be part to educate or be part of this education, so that no one can understand this is treatable even in metastatic stages. Life can be in years, not few months. Most of this cancer now we have treatment which can prolong their life. Early stages cure is possible, and there are many more therapies which are coming up and which we are looking at. One day we will be able to cure the cancer. Thank you.
Thank you, sir. Thank you for your time.
Thank you.